Hello, good evening friends. This is Dr. Jambukeswaran, PrepLadder Orthopedic faculty for you. Today we are going to discuss the LRR FMGE 2026. Okay, this is last resort revision in YouTube, and just we are going to discuss very rapidly the important topics. How I selected? No, I selected the topics that has been repeatedly asked in past 5 years FMGE questions. So all these are asked topics. All these topics are very important. By this time, you know this thing. Okay. So we'll see very rapidly, right? Moving on to the first question. A 30-year-old male presented with complaints of unable to extend his wrist for the past 2 days. He is not able to extend the fingers. So wrist is dropped, finger is dropped, as well as elbow. He is not able to extend the elbow also. So probable level of lesion. Is it in the axilla? Is it in the arm? That's radial groove, or elbow or wrist? Obviously, this is a case of wrist drop. Where is the lesion? Okay, by this time you would have guessed the answer. The right answer is axilla. Okay, because he is not able to extend the elbow. Triceps is gone. When triceps is gone, the level of lesion is axilla. Okay, yes. Now you see what are the causes for radial nerve palsy. Common cause is in the arm. Number one, it's a Holstein-Lewis fracture. In our main recording, we had discussed very thoroughly what is Holstein-Lewis fracture. Holstein-Lewis fracture is it is fracture shaft of humerus that is happening in the proximal 2/3, distal 1/3 junction. That is at the lower level. And the fracture will be, the pattern of fracture is oblique with an already entrapped radial nerve. So I repeat once again, what is Holstein-Lewis fracture? Fracture proximal 2/3, distal 1/3 junction, an oblique fracture shaft of humerus with an already entrapped radial nerve. So patient will present to you with a wrist drop. That is the first cause. Second thing, crutch palsy. Crutch palsy, you see here, most of us, we have a wrong notion, wrong thinking. Crutch is kept like this, okay? So you think crutch palsy, you think the lesion is at the axilla. That is wrong. Lesion is not at the axilla. So you see crutch, how they will walk, no? Suppose this is that wooden thing, bar of the crutch, it is like this. To hold that, no, I will compress, I will adduct my arm to the maximum level possible so that, no, to grip the crutch. So compression is happening at the level of arm, not at the level of axilla. Because axilla is fully padded with fat, man. So that easily it can't. Only run over accidents, major RTAs, otherwise falling from a tree branch, suddenly catching brachial plexus got injured. So axilla, most of the time it follows a very violent trauma, run over accidents. Usually in crutch palsy, it is due to compression at the level of the arm, not at the level of axilla. This is the concept I want to stress. Okay, so crutch palsy. Number three, Saturday night palsy. See, after consumption of alcohol, because they become unconscious, they are sleeping in a chair like this, in this position. You see here, in this place, your radial nerve is compressed at the level of arm. So Saturday night palsy. Problem in the forearm. The causes of radial nerve palsy in the forearm is elbow dislocation, fractures around the elbow. For example, lateral condyle fracture of the humerus. Then a tight POP cast, very, very important cause for radial nerve palsy at the level of forearm. Then it can be still below, radial tunnel. Radial tunnel in the forearm, the nerve may be compressed at the tendinous origin of supinator, and that's called arcade of Frosch. Okay, so that's called radial tunnel syndrome. Like your carpal tunnel syndrome, there is something called radial tunnel syndrome. Okay, right. And lowermost at the level of wrist, this is called Waardenburg's palsy. It is entrapment of the superficial sensory branch of radial nerve in the distal forearm, that is especially wrist. Okay, this Waardenburg syndrome, they will present you only with sensory loss over dorsum of the hand. They won't have any weakness of the muscle because only the superficial sensory branch is compressed. Radial nerve is compressed. Most of the time it is neuropraxia. Usually in olden days this happens because the prisoners, So the thieves or robbers, when they got the policemen, they will wear a cuff, okay, heavy cuff that causes compression. Okay, this is called Wardenberg syndrome. Nowadays, a heavy watch can cause this. So the another name for Wardenberg syndrome is watch palsy. Another name for is called watch palsy. So radial nerve compression can happen in 4 levels: very high axilla, high in the arm, low in the elbow and forearm, very low at the level of wrist. Okay, so how they will present according to level of lesion. If axilla, the lesion is at the level of axilla, the main thing is elbow extension is lost. Wrist drop with unable to extend the elbow, the cause is at axilla. All other things will be there. Wrist extension is lost, finger extension is lost, sensation over the posterior part of the forearm and dorsum of the hand, especially in dorsum of the hand in the first web space. Okay, this first web space, dorsum of the hand, first web space is called autonomous zone of radial nerve. Otherwise, it's called eye of the radial nerve. So, ask the patient to close his eyes with a wisp of cotton. You are checking the sensation over dorsum of the first web space. If the sensation is lost, definitely that is a case of radial nerve palsy somewhere. Okay, so it's called autonomous zone or eye of the radial nerve. So this feature, okay, dorsum of the hand, especially first web space, is very important. If it is at the level of radial groove, that is at the arm, this is the most common site where fracture shaft of humerus is the commonest cause, especially your Holstein-Lewis fracture. Okay, so here elbow extension is possible. Elbow extension is present, it's possible. All other things are lost. Okay, so at the level of arm, at the level of at or below elbow, if it is isolated posterior interosseous nerve palsy, sensation is spared. This is a very important point I want to stress. Only motor weakness, sensation is spared. In this type, only they will reframe the question. This is an asked question. Radial nerve palsy several times asked FMGE area. They may ask in posterior interosseous nerve palsy, specifically if they ask, sensation is spared. This is the point I want to stress. Only finger and thumb drop will be there. Okay, sensation or dorsum of the hand is preserved. In distal radial sensory lesion at the wrist, this is called Wardenberg syndrome. No motor weakness. Already I told you, only sensation is lost. These two things are exemptions, so kindly concentrate. If the level of wrist, no motor weakness, only sensory loss. If it's isolated posterior interosseous nerve palsy, sensation is preserved, only motor loss, that is wrist drop and the finger drop. Okay, finger and thumb drop. Only motor weakness. Okay, should be very careful. And how can we treat a radial nerve palsy, a wrist drop? Okay, you just extend, put a POP slab like this. This is called static cock-up splint. Cock, it is cock hen, how the cock will look. It will look like that. Okay, always lift his head like this and see. So it's called cock-up splint. When you put like this, it's called a cock-up splint. When spring is added, that's called dynamic cock-up splint. So this is the primary treatment. You can try nerve repair. Okay, even after 9 months, this is the criteria asked question. Even after 9 months, okay, power doesn't, okay, recover. You had done a nerve repair, 9 months is over, there is no improvement, you have to go for the definitive procedure. Last resort is tendon transfer. This is the question asked. When will you do tendon transfer in any peripheral nerve injury? Okay, even after nerve repair, 9 months, even after 9 months, there is no recovery. The last resort is tendon transfer. That's the final procedure. 2 procedures are available. One is called Jones triple tendon transfer. Another is called modified Jones. Jones triple tendon, 3 tendons are used. Pronator teres is used for extensor carpi radialis brevis. From flexor compartment, pronator is given for extensor carpi radialis brevis. Flexor carpi ulnaris is used for extensor digitorum communis. Palmaris longus is used for extensor pollicis longus. These 3 tendons are used. So this is called Jones triple tendon transfer. The problem with this is, since you are using 3 tendons, multiple scars, cosmetically very ugly looking, large incisions, cosmetically very bad. More than that, since you are transporting the pronator teres from here to here, this place, whenever the patient extends, a bulge will come. That is called pronator bulge. That is called pronator bulge. These are the disadvantages of Jones triple tendon transfer. To overcome this, modified Jones tendon transfer, this is the treatment of choice nowadays. This is the treatment of choice. Best treatment, best tendon transfer for radial wrist drop is modified Jones transfer. See here, only two tendons are used. Palmaris longus is used for extensor pollicis longus. Flexor carpi radialis is used for extensor digitorum communis and extensor carpi radialis longus. Here, advantage, less scar, cosmetically better, 100% no pronator bulge. So, this is the treatment of choice. Okay, we will move on to the next question. Okay, all are clinical tests to evaluate ulnar nerve injury, because radial nerve injury, ulnar nerve injury, commonly asked nerve injuries in FMGE. Okay, we can expect a question for sure. Okay, all are clinical tests to evaluate ulnar nerve injury except cord test, Oshner's test, Egawa test, book test. By this time, you would have guessed the answer. The exception is Oshner's test. Oshner's test is otherwise called pointing index, that is seen in median nerve palsy. Cord test, Egawa test, book test. Book test is otherwise called Frohman sign. Classical clinical test for ulnar nerve injury. You see here, what is this cord test? You know, palmar intraossei and dorsal intraossei are supplied by ulnar nerve. Palmar intraossei and dorsal intraossei are supplied by ulnar nerve. So you are taking a cord, you are insinuating a cord between the fingers. You ask the patient to release the cord. If his palmar intraossei is intact, he can hold the cord, because the action of palmar intraossei is adduction. That is why the mnemonic for this is PAD. Usually in medical college anatomy, they will teach like this. Palmar intraossei causes adduction, PAD. Okay, so this is called cord test. The other way around, dorsal intraossei can be tested by Egawa test. The function of dorsal intraossei is abduction. That is why dorsal intraossei dab, abduction. This is the mnemonic, dab. Dorsal intraossei abduction. Palmar intraossei pad, adduction. So dorsal intraossei, what is that? Ask the patient to put his finger over a table. You ask the middle finger to sway between the index and the little finger like this. Okay, you are asking the patient to abduct the middle finger towards the ulnar, towards the ring finger and towards the index finger like this. This is called Egawa test. Okay, with the palm flat on the table, patient is asked to move the middle finger sideways. Okay, so this is for dorsal intraossei of the middle finger. Dorsal intraossei of the middle finger. Okay, so you should ask the patient to sway this side like this. Okay, so this is called Egawa test. So a very classical test for ulnar nerve. Then coming to Frohman sign, otherwise called book test. What is that? You just ask a patient to hold a book like this between the thumb and the index finger. Right? You try to pull the book. If my ulnar nerve is fine, adduction of the thumb is possible, so I can't release the book. Suppose if my ulnar nerve is injured, to compensate that, I will hyperflex the interphalangeal joint of the thumb like this. Then that means ulnar nerve is not acting. This is called Frohman test, otherwise called book test. I was talking about the exception Oshner's sign. Oshner's test, otherwise called pointing index. What is that? When I ask to clasp the fingers, I can clasp all my fingers like this. Suppose for right side median nerve injury is there, all other fingers I can flex. This index finger alone, I cannot flex the index finger. So index finger will point out like this. Okay, point out like this. So this is called a pointing index, otherwise called Oshner's clasp test. Otherwise called Oshner's clasp test. And church fathers used to do like this. So this is called benediction sign. So this is called benediction sign. This is called Frohman test. This is called Oshner's clasp test. the lesion is at median level, median nerve, not ulnar nerve. So that is the exception. And what do you mean by partial claw hand? Look at the diagram. Partial claw hand means only your little finger and ring finger has gone for clawing like this. So this is called partial claw hand. This is otherwise called true claw hand. That is only ulnar nerve is injured. Only ulnar nerve is injured. If ulnar nerve injury is associated with median nerve injury, all the fingers will go for clawing like this. And this is called total claw hand. This is called total claw hand. So if they ask the thing, what is partial claw hand? Pure ulnar nerve injury. Total claw hand, ulnar nerve plus median nerve injury. Right? What do you mean by ulnar paradox? Asked question. Higher the level of lesion in ulnar nerve, see, in radial nerve, higher the lesion, deformity is more. Yes or no? Very high. Axilla, patient will have wrist drop, finger drop, thumb drop. Elbow also will be like that, not able to extend the elbow. Whereas in ulnar nerve injury, everything is ulta. Higher the lesion, lower will be the deformity. That is called ulnar paradox. Higher the lesion, lower will be the deformity. Lower the lesion, higher will be the deformity. Okay, so this is called ulnar paradox. And what do you mean by tardy ulnar palsy? Tardy means very slow. Tardy means very slow. Very slowly developing ulnar nerve palsy is called tardy ulnar palsy. The cause is lateral condyle fracture. Lateral condyle fracture. In lateral, see, this is medial epicondyle, this is lateral epicondyle. Lateral condyle fracture, when it happens in a child, the complication is non-union and cubitus valgus. When the carrying angle becomes more, that is called cubitus valgus. Okay, this is called cubitus valgus. This is called gunstock, is called cubitus varus. So, lateral condyle fracture in a child, notorious to cause cubitus valgus. That will take years. That will take 4 to 5 years. Very slowly they will develop cubitus valgus. When the cubitus valgus gets worsened, your ulnar nerve is here, no, below the medial epicondyle, that will be stretched. So ulnar nerve claw hand, ulnar nerve palsy will develop, but it will develop very slowly, and that is called tardy ulnar palsy. And the cause one should not forget, and a UG should not forget. Okay, very commonly asked question in our PG exams, lateral condyle fracture in a child, tardy ulnar palsy. Okay, you should know this. Coming to treatment of claw hand, static procedures just to release the capsule alone. That is called Zancollis capsulodesis for claw hand. The tendon transfer, 2 tendon transfer procedures are available. One is called modified Bunnell, another is called Brand. When you use flexor digitorum superficialis, that is called Bunnell's technique. When you use extensor carpi radialis brevis, that is called Brand technique. So, please, these names, till you clear your FMGE, you should know. For a wrist drop, the best technique is modified Jones procedure. For claw hand, both are equally good. Modified Bunnell, Brand. Modified Bunnell is nowadays preferred. That's why I typed that above. Okay. So modified Bunnell, Brand. Okay. So all these are asked questions. High chance is there. They can repeat the same question. Okay. Yes. We'll move on to the next topic. Very important topic. Very favorite topic of FMGE. Okay. We should know. And it's a very straightforward question. Osteogenic sarcoma commonly metastasis to liver, bone, brain, lung. By this time you would have guessed. Okay. Osteogenic sarcoma commonly metastasis to lung. Commonly metastasis to lung. Because we know it is of hematogenous origin. It is of hematogenous because the spread is through blood spread, hematogenous spread. Okay. The bone tumor that is metastasizing to bone. Okay, this is very peculiar. Please listen now itself. If they ask a question, bone tumor metastasizing to bone, Ewing sarcoma will come. Ewing sarcoma. Actually, it won't metastasize. It spreads in the bone very quickly. So, bone tumor that is moving in a bone, okay, spreading in a bone, no, Ewing sarcoma. Okay, osteogenic sarcoma notoriously very easily will go to the lungs. Once pulmonary metastasis has happened, to treat it's very difficult. Okay, so osteogenic sarcoma, what are the points repeatedly they are asking? Most common non-hematological. Please, okay, I had 100 times I have stressed this point. If they ask a question, most common primary malignant tumor of the bone, please focus your fullest attention. Most common primary malignant bone tumor, if they ask a question, answer is multiple myeloma. It is not osteogenic sarcoma. Second common primary malignant bone tumor alone is osteogenic sarcoma. When you should say this is the most common non-hematological primary malignant bone tumor, it is osteogenic sarcoma. Otherwise, most common primary solid malignant bone tumor, it is osteogenic sarcoma. Okay, right. And it arises from multifactorial mesenchymal tissue. Ewing sarcoma arises from endothelial cells of the bone marrow. Osteogenic sarcoma arises from mesenchymal tissue of the cell. And most common age, several times repeated question, 15 to 25. Most common in male. Most common site, 1 lakh time repeated MCQ, distal end of the femur, upper end of the tibia. That means knee joint. Most common site of osteogenic sarcoma is knee joint. Age is 15 to 25. Classically, it metastasis to, okay, it arises from metaphysis of the long bone. See, whenever no malignant bone tumor, you should know in bone tumor where it arises from. Giant cell tumor arises from epiphysis. Ewing sarcoma arises from diaphysis. Osteogenic sarcoma arises from metaphysis. We should know, okay? Very important. And pain is the first symptom. Swelling appears few weeks later. Why? See, this is very concept-based area. You know, bone is insensitive. Bone is insensitive. Then which is sensitive? Periosteum is very sensitive. So osteogenic sarcoma, once it has started in the metaphysis, initially this will go and lift the periosteum. So periosteum is stretched, stretching of periosteum. Periosteum contains lot of free nerve endings. So it causes intense pain. So pain is the first symptom. When swelling will happen, it has to break open the periosteum. The tumor has to spread into the soft tissue. Then only you can appreciate the swelling. So that will take few weeks to few months. Okay. And osteogenic sarcoma is very dangerous because it spreads through blood and directly it will go and invade the lungs very fast. Once pulmonary metastasis happens, to treat it's very difficult. That is why. And so best thing is early detection, and radical ablation is the surgery of choice. Early detection and radical ablation is the surgery of choice. And combined approach is the best treatment nowadays. Aptly says combined approach means what? You are giving radiotherapy first to shrink the tumor. Then you are surgically excising the tumor. Following surgery, you are giving chemotherapy. This is called sandwich therapy. Otherwise, this is called combined approach. This is called combined approach. This is the best treatment. Suppose if they give in a MCQ, they are framed like this. Best treatment for osteogenic sarcoma. If they give radiotherapy, chemotherapy, surgery, something like that, you should go for surgery. If it in the 4 choices, combination of these 3 things, if they had given combined therapy, then that carries more weightage than surgery alone. Okay. So, and you should know BCG. Okay. BCG is a vaccine against tuberculosis. All of us know. BCG, when you give, it raises the immune status and some sort of protective factor against osteogenic sarcoma. This is a new concept. You should know which vaccine is helpful in raising immune status against osteogenic sarcoma. BCG. So when you read this BCG, when you read Bailey and Lowe carefully, BCG raises the immune status in one more tumor, bladder carcinoma. So BCG is helpful in treating bladder carcinoma, raises the immune status against bladder carcinoma. BCG increases the immune status in osteogenic sarcoma. Okay. Yes. Now, coming to the next question. Giant cell tumor arises from epiphysis, metaphysis, diaphysis, none of the above. Obviously, you know the answer. Just now, few minutes back, we discussed this. Giant cell tumor arises from epiphysis. Giant cell tumor arises from epiphysis. Okay. So, whenever you read a bone tumor topic, okay, I repeat once again for you. Ewing sarcoma, diaphysis. Giant cell tumor, epiphysis. Osteogenic sarcoma, metaphysis. Golden point. For FMGE, it's a golden point. I am telling you, from epiphysis, two bone tumors can arise. One is a benign tumor, another is a malignant tumor. Okay? Please focus your fullest attention. From epiphysis, two tumors can arise. One is a benign tumor, another is a malignant tumor. The benign tumor is chondroblastoma. The malignant tumor is giant cell tumor, otherwise called osteoclastoma. Okay, so how to differentiate? Very simple. In history, how to differentiate? Very simple. When it happens in a child before epiphyseal closure, they are giving an osteolytic lesion. You are seeing an X-ray. That X-ray is showing an osteolytic lesion in the epiphysis. Whenever you see osteolytic lesion in the epiphysis, two things are possible, I told you. A chondroblastoma and a giant cell tumor. When the epiphysis is not closed, it should be chondroblastoma. That is why chondroblastoma happens in epiphysis before epiphyseal closure. Giant cell tumor is a tumor that happened, the age group is 15 to 35 years. So, they had given an X-ray and the epiphysis is completely fused. Otherwise, they had given age group 30 years. It should be giant cell tumor. Okay? One should be very confident. If they given 4-year-old child, 5-year-old child, it should be chondroblastoma. A 30-year-old male, 25-year-old male, it should be giant cell tumor. Okay? This chondroblastoma is harmless, benign tumor. Giant cell tumor is a malignant tumor. Okay? That's the difference. You see, this is otherwise called osteoclastoma. I told you the age 13 to 15. All bone tumors, this age and sex is very important. Male. Most common site is lower end of femur, upper end of tibia, that is knee joint. Again, like your osteogenic sarcoma. Though it is benign, it acts locally malignant, like your cholesteatoma, which you have read in your ENT. Classically occurs in the epiphysis of long bone after epiphyseal closure. To stress this point only, I typed like this. Please register this in your mind. Swelling is the main complaint. Pain happens very late. Okay, because giant cell tumor, see, in a malignant bone tumor teaching, pain is the first symptom, swelling comes late, it is osteogenic sarcoma. Swelling is the first symptom, very rare, sometimes they don't have pain at all. Then that is giant cell tumor. Book says very clearly, in a giant cell tumor, when pain happens after pathological fracture. Once fracture happens, no, that is causing the pain. So, most of the time it is painless swelling, right? And on palpation, because of soap bubble appearance, okay, palpation gives eggshell crackling like sensation. Eggshell crackling like sensation. Extended curettage is the best treatment. And if they ask a question, is there any drug therapy for giant cell tumor? Drug of choice for giant cell tumor is denosumab. Expected question, dear friends. MAB means monoclonal antibody. MAB means monoclonal antibody. What is this denosumab? You know, giant cell tumor is otherwise called osteoclastoma. So, I want to give a drug that slows the osteoclastic activity. Denosumab is an agent which increases the maturation time of osteoclast. Increases the maturation time of osteoclast. So, osteoclastic activity comes down. When osteoclastic activity comes down, giant cell tumor will improve. Okay, so drug of choice for giant cell tumor is denosumab. Highly expected question in ortho as well as pharmacology. Okay, right. You see here, we will go on to the next question. A 6-year-old child diagnosed to have Ewing sarcoma, best treatment is radiotherapy, chemotherapy, surgery, conservative. This is a tricky question. Whenever a question Ewing sarcoma, the thing that will come to your mind, first thing is radiotherapy. Because you had read several times, a highly radiosensitive tumor is Ewing sarcoma. So radiotherapy will come to your mind first. That is wrong. Treatment of choice for Ewing sarcoma is surgery, surgery, surgery. Okay, should be very careful. You see, this Ewing sarcoma is otherwise called small blue cell tumor. It arises from endothelial cell of bone marrow. Why specifically in bold letter I has typed? Because from bone marrow, two malignant bone tumors are arising. One is Ewing sarcoma, another is multiple myeloma. Multiple myeloma happens in age group 70 and above. So two tumors are arising from bone marrow. So you tend to get confused. Endothelial cell of bone marrow, it is Ewing sarcoma. Plasma cell of bone marrow, it is multiple myeloma. Endothelial cell of bone marrow, it is Ewing sarcoma. Plasma cell of bone marrow, it is multiple myeloma. So the most common site of Ewing sarcoma is again lower end of femur, upper end of tibia, that is knee joint. See, the age is 5 to 25, male sex. Classically happens in diaphysis. Already I told this point. Highly sensitive to radiotherapy, but be careful at this point. It is radiosensitive. The Ewing sarcoma, when you give radiation, it will melt away, but again it will come. So the definitive treatment of choice is not radiotherapy, surgery. And the cytogenic abnormality, it has shown that there is translocation of chromosome 11 and 22. Chromosome 11 and 22. Chromosome 11 and 22. Okay, translocation of 11 and 22. That is a chromosomal cytogenic abnormality. Okay, because please focus your fullest attention. The cytogenic abnormality that is seen in osteogenic sarcoma is 13q14. Translocation of 13q14. Same thing we had read in retinoblastoma also. That is why 13q14 is called RB gene, retinoblastoma gene, RB gene. Okay, right. So retinoblastoma and your osteogenic sarcoma are interrelated. Like that this 11 and 22, the same, this is the cytogenic abnormality that is happening in neuroblastoma. So Ewing sarcoma is related to neuroblastoma. Robbins says that somebody who has developed retinoblastoma, high chance of developing osteogenic sarcoma. Somebody has developed osteogenic sarcoma, or high chance of developing retinoblastoma because of the same cytogenic abnormality. And they present with pseudo rosette formation. True rosette is osteogenic sarcoma. Pseudo rosette is Ewing sarcoma. Very important. Asked question. Clinical presentation resembles osteomyelitis. They will, because waxing and waning of symptoms, bone pain. Some patients can present to you even like with a pus. Okay. Yes. And the treatment, the chemotherapeutic agent for Ewing sarcoma, please don't forget, it's called VIDE regime, VIDE. Vincristine, ifosfamide, doxorubicin, etoposide. Okay, VIDE regime. Vincristine, ifosfamide, doxorubicin, etoposide. Surgery, after chemotherapy, you give a chemotherapy, remaining tumor surgically resected, and you focus your full attention on the last point. Radiotherapy not routinely used, as it causes growth disturbance in growing child. Reserved only for localized lesion. Okay, radiotherapy is not routinely used. What is the question I asked? 6-year-old child. When you give radiotherapy, what will happen? Tumor may shrink temporarily, but this will go and damage the epiphysis. So the growth of the bone will be affected. So the treatment of choice is surgery, surgery, surgery. Please don't forget this point. We will move on to the next tumor. This is an image-based question. Look at the X-ray, give your diagnosis. The tumor is Ewing sarcoma, osteoclastoma, multiple myeloma, osteogenic sarcoma. By this time you would have guessed. Okay. So this is the classical, okay, this is the classical sunburst appearance. This is the classical sunburst appearance. So the answer is osteogenic sarcoma. This is the answer. You see, just we will discuss quickly, we will see the X-ray findings of the 3 important malignant tumors. Here, when you focus your attention, the periosteum is lifted like this. This is called Codman's triangle. Codman's triangle. So this is a classical feature of osteogenic sarcoma. Codman's triangle, osteogenic sarcoma. The second image, very classically from a tumor, lesions of blood vessels goes like this. Blood vessels you can't see, but you can see microcalcification along the vessel wall. This gives the classical sunburst appearance. This is sunburst appearance. So very, very classical of osteogenic sarcoma. Okay. So this is osteogenic sarcoma. Right. This is Codman's triangle. When I see here, I am seeing an osteolytic lesion in the metaphysis. I am seeing an osteolytic lesion in the epiphysis. This is epiphysis, no? So in the epiphysis, multiple small tubercules I am seeing. This is the classical soap bubble appearance. This is the classical soap bubble appearance. Very classical of giant cell tumor, otherwise called osteoclastoma. When I see the next X-ray, when you zoom your app and see, I will first draw and I will erase. You just see multiple striped layers of periosteum. Okay, periosteum is divided into multiple striped layers. This is called onion peel appearance. This is called onion peel appearance. Very classical of Ewing's sarcoma. Onion peel appearance. Very classical of Ewing's sarcoma. The next slide, when you see, this looks as if this is unasked question. So far in any of the Indian entrants they had not asked. This is the classical moth-eaten appearance. Moth-eaten appearance. Moth-eaten appearance classically happens in Ewing's sarcoma. Moth, like a moth had eaten the leaf, like that. Moth-eaten appearance of the bone when they ask a question. So far unasked in any of the Indian entrants. This is purely a new question to you. Moth-eaten appearance of the bone. The choice Ewing sarcoma is there. That is the right answer. Okay. So in short, we have completed very important X-ray appearance of the malignant tumors. We'll move on to the next question. All are risk factors for malignant transformation in exostosis except. All are risk factors for malignant transformation in exostosis except. Okay, this is very important question. Okay, so this exostosis is a favorite area of FMGE. So far they had asked the other areas. Exostosis arises from metaphysis. Exostosis happens in puberty. Treatment of choice for exostosis. They had asked this. But this is there in exostosis. So far unasked in FMGE. This may be the future this year question. All are risk factors for malignant transformation in exostosis except multiple hereditary exostosis, sessile exostosis, cartilaginous cap thickness more than 1 centimeter, sudden increase in size. So these are the 4 choices. Which is the exception? All are risk factors except. By this time you would have guessed. Cartilaginous cap thickness more than 1 centimeter is the exception. Okay. Because cartilaginous cap thickness more than 2 centimeter is the answer. Not 1 centimeter. Okay. So what are the risk factors and signs of malignant transformation? This is the most important slide, dear friends. Please focus your fullest attention. 1% chance in solitary osteochondroma, that is simple exostosis, only 1% chance. Okay. Hereditary multiple exostosis, 5% chance. Multiple hereditary exostosis, 5% chance. So hereditary multiple exostosis or multiple hereditary exostosis, very notorious to get transformed into malignancy. Point number 1, first risk factor. Second risk factor, you see, sessile is the second risk factor. You see, exostosis can be of 2 types. Sessile, pedunculated. Pedunculated means with a stalk. That is the commonest type. That has less chance of malignant transformation. If it is sessile, means attached, no stalk, directly attached to the bone, then that is highest chance of getting into malignant transformation. So second risk factor. Then osteochondroma transformed to low-grade chondrosarcoma, sudden increase in size. Sudden increase in size. very dangerous sign of exostosis. And new onset pain without any history of trauma. No trauma, nothing has happened. Exostosis is there for 5 years in a child, in a guy, and suddenly he is complaining of pain. But obviously there is no history of any trauma. One should suspect malignant transformation. Then this is the criteria. This is the criteria. Most important criteria. Cartilaginous cap thickness more than 2 centimeters in MRI. That is why in all cases of exostosis, better you do an MRI, measure the cartilaginous cap size. When cartilaginous cap size is more than 2 centimeter, is highly prone for malignant transformation. So you have to remove it immediately. Okay, and obviously it is confirmed by biopsy. Okay, so this is a very, very important slide, very important question. And other things in exostosis, no need to tell. For your sake, I revise for you. Exostosis happens during maximum onset during puberty, teen age, more common in boys, most common around knee joint, arises from metaphysis, painless swelling. Pain comes in exostosis, suspect adventitious bursitis, malignant transformation, fracture of exostosis, or exostosis compressing a nerve. The classical appearance of exostosis, gross appearance called cauliflower like appearance, cauliflower appearance, the gross pathology. Okay, it arises an exophytic growth in an X-ray. Okay, right. So these are the things, and the best treatment is excision. Complete extraperiosteal excision is the treatment of choice. What is the treatment of choice for exostosis? Extraperiosteal excision. Extra means excessive margin you should do, not to the stalk. Just few centimeters around the stalk should excise. That's called extraperiosteal excision is the treatment of choice. Now we'll move on to the next question. Most common association of Sprengel shoulder is CDH, CTEV, Down syndrome, Klippel-Feil syndrome. By this time, easily you would have the answer. Okay. Most common, 1 lakh time repeated question. Again, this will be a question. Very favorite area of FMGE, Sprengel shoulder. Okay. Most common association is always Klippel-Feil syndrome. 90% of Sprengel shoulder is associated with Klippel-Feil syndrome. Okay. Whenever you see a Klippel-Feil syndrome, it will be associated with Sprengel shoulder. Okay. So, what is this? Most common association is Klippel-Feil syndrome, KPS. What is this Sprengel shoulder? Sprengel shoulder is nothing but congenital elevation of the scapula. Okay. It is you see here in this slide, this side scapula is at this level, this side scapula is at higher level. So, congenital elevation of scapula is called Sprengel shoulder, congenital elevation of scapula. This again, except for cosmetic reason, this is a harmless condition. Why I am telling? The only presentation is, see, if you have a normal shoulder, easily can abduct. When I have a Sprengel shoulder, slight limitation of abduction. That's all. Slight limitation of abduction. That's the only presentation. Why this Sprengel shoulder is happening? No? In intrauterine life, there is a structure called omovertebral bone. Omovertebral bone. Omovertebral bone means, don't think the word is omovertebral bone. It is actually speaking, it is not. It's a thickened fascia. Normally, all our scapula during intrauterine life will be at the cervical level. At the cervical level. As the baby, the fetus grows inside the uterus, from cervical level, during birth, scapula will come to the thoracic level. It should descend. Because this omovertebral fascia will get obliterated. In some fetuses, this omovertebral fascia is persistent. So, on that side, it won't affect the scapula to descend down. So, the baby will be born with a congenital elevated scapula. This is the pathogenesis. If at all you want to do something, you have to do surgery. And surgery is effective only when you do it before 6 years. Otherwise, it is ineffective. After 6 years, it becomes ineffective. Okay. And this is the classical triad of Klippel-Feil syndrome. This is the classical triad of Klippel-Feil syndrome. It is short neck, low hairline, restricted neck movements. What is this Klippel-Feil syndrome? This is nothing but congenital fusion of the cervical vertebrae. We have 7 cervical vertebrae, C1, 2, 3, 4, 5, 6, 7. All are separate like this. If 2 or 3 vertebrae congenitally get fused together, what will happen? All the cervical vertebrae fused together, the neck length will become shortened. So, congenital fusion of cervical vertebra, patient will have a short neck. Because of short neck, they will have low hairline. When you see short neck with low hairline, immediately Down syndrome will come to our mind. In Down syndrome, there is mental retardation. One good thing about Klippel-Feil syndrome, absolutely the mind is not affected. Normal brain growth. Only thing is, because of congenital fusion of the cervical vertebra, you know the second cervical vertebra is called the axis because that aids in axial movement like this. Okay, so that is lost. So whenever you call, they will turn and they will see like this. This is the only problem. Otherwise, there is no problem. Okay, so this is called Klippel-Feil syndrome. Whenever you see Klippel-Feil syndrome, it will be associated with Sprengel shoulder. Unless other is proven. Whenever you see a Sprengel shoulder, it will be associated with Klippel-Feil syndrome. Okay, so this is the importance of this question. Okay, right. In Klippel-Feil syndrome, when you take an X-ray of the cervical vertebra, I told you, it is all the cervical vertebrae are fused to one unit. You see here. So these two vertebrae, they are looking separate. These vertebrae got fused together. Yes or no? Okay. So look like a block vertebra. And this goes by a name. See, here the vertebra is broad. In lower also, the vertebra is comparatively broader. In between the fused vertebra, they are narrow. And is it not looking like somebody's waist? And so this is called wasp waist sign. Wasp waist sign. So far unasked in any of the Indian entrance, so this may be a new question. Wasp waist sign of cervical vertebra, the diagnosis is Klippel-Feil syndrome. Okay, CT scan is the best investigation and there is no definitive treatment for Klippel-Feil syndrome. Okay, except for cosmetic reason, it's a harmless condition. We'll move on to the next question. All are predisposing factors for recurrent shoulder dislocation except very favorite area of FMGE. Recurrent shoulder dislocation. Already they are asked a different question. So all are predisposing factors except old age, initial dislocation following a trivial trauma, collagen disorder, inadequate immobilization. By this time you would have guessed the answer. All are predisposing factors for recurrent shoulder dislocation except old age. Because young age is the predisposing factor. In old age only capsules will get torn. So most of the time they won't go for recurrent shoulder dislocation. So now let us see. Most of the recurrent shoulder dislocation is also of anterior type. We know most common type of shoulder dislocation is anterior. Second common type is posterior. The least common type is inferior. So like that, recurrent shoulder dislocation also the most common type is only anterior. The predisposing factors are age below 20 years. First time dislocation is happening in a guy and his age is below 20 years, highest chance. Then inadequate immobilization, minimum 3 to 4 weeks even after reducing the shoulder dislocation because the ligaments, the capsules, the labrum has to heal. Okay, when you don't immobilize, inadequate immobilization, highest chance they will go for recurrent shoulder dislocation. Collagen disorders, this is very rare like Ehlers-Danlos and Marfan's. In our setup, it's very rare. When the initial dislocation happened following a trivial trauma, that says that already his ligament structures are weak, right? And one should not forget these three things: Bankhart's lesion, Hill-Sachs lesion, erosion of the anterior glenoid labrum. What is Bankhart's lesion? Bankhart's lesion is a soft tissue lesion. Everything is very detailed with a diagram explained in our main recording. Bankhart's lesion is a soft tissue lesion which happened. What is that? There is a tear in antero-inferior aspect of the glenoid labrum. Bankhart's lesion is antero-inferior tear. Okay, in the glenoid labrum. That is called Bankhart's lesion, which is a soft tissue lesion. Hill-Sachs lesion is a bony lesion, a depressed fracture in posterolateral aspect of the head of the humerus. Okay, so Hill-Sachs lesion is a bony lesion, a depressed osteochondral defect, a depressed fracture like thing in the posterolateral aspect of head of the humerus. So this is Hill-Sachs lesion. Then erosion of the glenoid labrum, right? Usually more than one lesion occurs in the same patient. When Bankhart's lesion with Hill-Sachs lesion and erosion of glenoid labrum is happening in the same shoulder, highest chance it will go for recurrent shoulder dislocation. The asked question was Bankhart's lesion, Hill-Sachs lesion. Okay, please don't forget. Then classification of recurrent shoulder dislocation is called Matson's classification. It's divided into two types: Tubbs, Ambry type. Tubbs means, see, T for traumatic, U for I will explain, unidirectional, B for Bankhart's, S for surgery. Okay, this is atraumatic, multidirectional, bilateral rehabilitation. This is the simplest way of remembering this very important area for FMGE. See, a recurrent shoulder dislocation can be Tubbs type, Ambry type. Tubbs type means recurrent shoulder dislocation happens because of trauma. Okay, some trauma has happened. And most of the time unidirectional. That means 2 or 3 times the shoulder getting dislocated, but it is getting dislocated only in one direction. For example, first time anterior, second time anterior, third time anterior, then that is called unidirectional. You are taking an MRI is showing Bankhart's lesion. Okay, treatment of choice is surgery. Other way around, recurrent shoulder dislocation is happening, no history of trauma, atraumatic. And multidirectional, first time anterior, second time it's posterior, third time again anterior or inferior, something like that. It's called multidirectional. And both shoulders are involved, bilateral. Then don't do surgery. Surgery won't help. Only physiotherapy, that is rehabilitation. So if they ask, they will ask like this: traumatic recurrent shoulder dislocation, best treatment option, surgery. Atraumatic recurrent shoulder dislocation, best treatment option, answer is rehabilitation, physiotherapy. Okay, yes. Now clinically, apprehension test positive. Patient, no, whenever you ask him to abduct the shoulder with a fear, he will apprehend. The apprehension will be there in his face. Fear will be there in his face, because he thinks that whenever I abduct, no, my shoulder will get dislocated. So apprehension test. And when you just flex the elbow and just slightly pull the elbow downwards, you can see, I think you'll be able to see a dimple here. Okay, so this is called Neer and Foster's sulcus sign. Very, very important. Whenever you see this Neer and Foster's sulcus sign, says that this is a case of recurrent shoulder dislocation. And the investigation of choice, obviously MRI, because I want to see with the glenoid labrum erosion, I want to see Bankhart's lesion. Soft tissue lesions can be detected only by MRI, not X-ray. So for recurrent shoulder dislocation, investigation of choice is MRI. This is an expected question. Please don't forget. Coming to treatment, just remember Bankhart's procedure, best treatment. See, there is a tear in antero-inferior aspect of the glenoid labrum. I am suturing, I am repairing it through arthroscopy. That's called Bankhart's procedure. This is the procedure of choice. Second thing, asked question, Latterjet procedure. Latterjet procedure means, in scapula, that's called coracoid process. The coracoid bone is transferred in front of the shoulder so that anterior shoulder dislocation won't happen again. Coracoid is kept in front of the shoulder. Okay, that is called Latterjet procedure. When you double breast the subscapularis muscle, that is called Putti-Plott's procedure. So there are more than 13 to 15 names there. Repeatedly asked, no, you should not forget this name. Bankhart's procedure, Latterjet procedure, Putti-Plott's procedure. UG should know these three. Okay, we'll move on to the next question. Traumatic spondylolisthesis of C2 is called. Traumatic spondylolisthesis of C2, second cervical vertebra, is called Jefferson's fracture, Hangman's fracture, Chance fracture, Clay-Scholes fracture. By this time, you would have guessed the answer. Traumatic spondylolisthesis of C2 is called hangman's fracture. Okay, it is called hangman's fracture. Right? What is this hangman's fracture? It is traumatic spondylolisthesis of C2. The cause is hanging, either suicidal or in court verdict, somebody in gallows, no, hanging, caused traumatic spondylolisthesis of C2, sudden respiratory arrest and death. That is why this is called hangman. Okay, rarely this can happen in RTA. Okay, RTA, road traffic accident. Mechanism, this is hyperextension injury with bilateral avulsion of the neural arch from the vertebral body. When you see fracture is through pars intra-articularis, you see here is the fracture. It is through the pars intra-articularis of the C2. Okay, second vertebra, right? And Levin and Edwards classification, don't get scared. Type 1, type 2, type 3. Just remember, type 1 is the mildest form, type 3 is the worst form. Only when we know what type, then only we can plan for management, because they will ask what is the treatment for hangman. Simply we can't say one answer. 3 different answers are there. Type 1, displacement less than 3 millimeters, the fracture line, there is no angulation, there is no anterior angulation. Type 2, displacement more than 3 with anterior angulation. Type 3, the worst form, bilateral fascial dislocation with angulation. Okay, neurological deficit can happen in type 3. So type 1, if it is type 1, that is just fracture is there through pars intra-articularis, it is not at all displaced, there is no angulation of the vertebra, you can just with the rigid cervical collar for 8 to 12 weeks, conservative. If it is type 2, there is mild displacement with anterior angulation, you have to admit the patient, give a traction of the head and neck followed by halo vest for 12 weeks. If it is type 3, that is, there is displacement angulation with bilateral fascial dislocation, you have to do surgery, surgical stabilization, reduction with surgical fixation. Otherwise, patient will end up in neurological deficit. Okay, so this is called hangman's fracture. This is about hangman's fracture. Now I will tell you what is this Jefferson's fracture. Jefferson's fracture is burst fracture body of C1. What is Jefferson? Burst fracture, B-U-R-S-T, burst fracture of body of C1 is called Jefferson's fracture. How the patient absolutely no neurological deficit, because it is happening in body of the atlas, no neurological deficit. Only thing is severe neck pain. When skull presses the neck, they will develop pain. So patient will pull up the skull by the mandible, supporting the mandible, they will come to the OP like this. Okay, when they leave, they will have severe neck pain. So that is called Jefferson, burst fracture of body of C1. Best thing is rigid cervical collar for 8 to 12 weeks. Problem is solved. Harmless fracture. Chance fracture happens in seat belt injury. Okay, it is seat belt injury. This happens in thoracolumbar junction. Most common site is in thoracolumbar junction. Lumbar junction. Okay, it is flexion extension type of injury that is happening in thoracolumbar junction in car clash accidents, high velocity injury. Okay, so this is called chance fracture. It is a flexion extension type of injury, and it's a horizontal fracture, will involve all layers of the vertebra. It will cross the vertebral body, lamina, pedicle, and spinous process, everything. So it's called a chance fracture. This should be stabilized. Then Clay-Scholes fracture is again a harmless fracture. It is an avulsion fracture of the spinous process of the C7. Avulsion fracture of spinous process of C7. Seventh cervical vertebra has the longest spinous process, When spinous process got avulsed, a fracture happens in spinous process. Again, it's a harmless fracture. Except neck pain, nothing will happen. So, this is a harmless fracture. This is a harmless fracture. This type 3 is very harmful. Chance fracture has to be stabilized. Okay. So, these are vertebral fractures. Expected question. Okay. Yes. We will move on to the next question. A 30-year-old male, okay, presented with history of recurrent osteomyelitis. Underline the word recurrent osteomyelitis of his jawbone. Hip X-ray was taken, which shows the following finding. What is the probable diagnosis? Is it phosphorus poisoning? Is it osteopetrosis? Is it adamantinoma? It is slipped capital femoral epiphysis. Okay, whenever a word osteomyelitis, jawbone, your mind will go and just will think of phosphorus poisoning. Phosphorus poisoning causes what is called phossy jaw. Okay, phossy jaw. That is acute picture similar to acute osteomyelitis of the jawbone. It is not recurrent. Whenever somebody presents with recurrent osteomyelitis of jawbone, the diagnosis is osteopetrosis. Adamantinoma can happen in jaw, but that's a totally different condition. And the X-ray I had shown very classically gives what is called bone within bone appearance. Bone within bone appearance. The diagnosis is confirmed. This is osteopetrosis. You see, you are able to see here, this is a bone. You are seeing some bone inside a bone. Okay. So, this is called bone within bone appearance. That is osteopetrosis. Okay. Otherwise called marble bone disease. So, this is a basic defect in osteopetrosis is failure of osteoclast to resorb the bone. Bone modeling and remodeling are impaired. The end result is increased bone mass, but a fragile bone. The bone are brittle and break even with trivial trauma. So, osteopetrosis is otherwise called marble bone disease. Robbins pathology gives a word Alberg-Schonberg's disease. Okay, pathology term. It is autosomal dominant recessive. Two forms are there. Dominant is the most common type. This is the mildest form, usually diagnosed in adulthood. Classical clinical presentation, the fracture following a trivial trauma, especially ribs and long bones. There can be recurrent osteomyelitis of the jawbone. Unexplained recurrent osteomyelitis of the mandible, jawbone. One has to suspect osteopetrosis. And X-ray, this is a normal femur X-ray. You are able to see this is the cortex. Inside it is the medulla. Okay, normal corticomedullary differentiation is there. When you see, everything looks like a marble. So, this is osteopetrosis. This is the classical marble bone appearance. Okay, marble bone appearance. This is marble bone appearance. When you take X-ray of osteopetrosis, I am able to see an osteosclerotic line here and here. Here it is translucent. And inside the translucency, I am seeing again opacity. I will erase. See, I am seeing opacity here. I am seeing opacity here. I am seeing translucency. Inside that, again an opacity. Okay, I will rub. You just see. This is called sandwich vertebra. Like a sandwich. Sandwich vertebra. Okay. So, sandwich vertebra, osteopetrosis. And this is the classical, you are able to see, this is a bone, inside I am seeing a bone like thing. This is a bone, inside a bone I am seeing. Here you see, this is a bone, inside I am seeing a bone. So, this is called bone within bone appearance. Only diagnosis is bone within bone appearance. Only diagnosis is osteopetrosis. Okay, osteopetrosis. You should not forget. And there is no definitive treatment for osteopetrosis. Okay, that stem cell therapy and all, it is coming up, but not proved. Right. All are clinical tests for developmental dysplasia hip, otherwise called congenital dislocation hip, CDH or DDH. Okay, Ortolani's test, Barlow's test, piston test, knee axilla test. Very simple, straightforward question, because DDH is a very favorite area of FMGE. Okay, by this time you would have guessed the answer. Yes, all are clinical tests for DDH except knee axilla test. Except knee axilla test. Knee axilla test, focus your full attention, guys and girls. Focus your fullest attention. Knee axilla test is, some books uses the word sectoral sign. Knee axilla test is, in a normal individual, make a normal individual lie down in a supine position, flex fully the hip, flex the knee joint fully. The knee should move. When I flex like this, no, for example, this is my lower limb, this is my knee, this is my hip, imagine. Okay, so this is my opposite nipple or opposite axilla. When I flex, no, this should move towards, my knee should move towards opposite nipple or opposite axilla. This is normal. When I am flexing the hip and knee fully, when the knee joint is going towards the same side axilla or same side nipple, that is abnormal, and that is called knee axilla sign. The diagnosis is slipped capital femoral epiphysis. So, slipped capital femoral epiphysis. When knee axilla sign is positive, the diagnosis is slipped capital femoral epiphysis. These three are classical tests of developmental dysplasia hip. Developmental dysplasia hip is uncommon in India because the way we carry our baby. Mother used to carry the baby like this. So even the baby is born with the developmental dysplasia hip, automatically that gets corrected. In Western people, they will swaddle the baby in a thing like this. Because the climatic condition, they will do like this. So a dislocated hip will be a dislocated hip. It won't get reduced. So it is uncommon in India, very common in Europe. Girl-boy ratio is 7:1, more common in girls. Mostly unilateral left hip, asked question. Most common side of developmental dysplasia hip, unexplained answer, left side. The abnormality range from mild established dysplasia to dislocation of femoral head. Incidence is 1.5 per 1000 live birth. This is the most important slide. What are the risk factors or predisposing factors for developmental dysplasia hip? Number 1, fetal malposition, breech. Repeated question FMGE, breech is the first risk factor. Second risk factor, firstborn child. 60% DDH firstborn. Third, female child. I said 7:1. 7 female, only 1 male. Then fourth, family history positive. Some family history is there. Then full term. See, most of the conditions are common in preterm. Dear guys, this DDH is common in full term. Because only in full term, in a normal labor, what happened? They say, aptly says, a theory called hormonal theory. That hormone is called relaxin, RELAXIN, relaxin. Relaxin is secreted by the mother, which relaxes the pelvic floor ligaments so that parturition becomes easy. So in full term, that relaxin is causing some, by unexplained way, it is causing ligament laxity in the newborn, in the fetus, and that is causing developmental dysplasia, that is causing dislocation of hip. That's called relaxin theory. So full term. Fetal package anomaly like oligohydramnios, and when it is associated with foot anomalies like metatarsus adductus. So 7 predisposing factors, repeatedly asked area. Please focus your full attention. The earliest clinical manifestation is limitation of abduction. Very important early sign, because in DDH they will have contraction of the adductors. So limitation of abduction. Asymmetry of the gluteal fold. You see here, one gluteal fold is here, another should be here only. But when you see this picture, one fold is here, another fold is here. So it is asymmetry of the gluteal folds. Very important thing. Right? There will be shortening of the leg or additional crease in postero-middle aspect of the upper thigh. Coming to the test, Ortolani's test, Barlow's test, telescopic test, that is called piston sign, Galeazzi, that is called Ali's test. 4 important things, repeatedly asked question. Ortolani's test is called test of entry, and I want you to note this special point. It will be positive only in first 2 months. When the baby becomes 3 months or 4 months, you can't elicit Ortolani. Barlow's test, telescopic test, Ali's test, or Galeazzi sign. Galeazzi sign is, or Ali's test is positive only in a child older than 2 months. Okay, older than 2 months. These 2 special points I will explain one by one. Ortolani's test is called a test of entry. It's called test of entry. What is that? You are receiving a newborn. That newborn is already having a dislocated hip. You are trying to reduce the hip. You are trying to relocate the hip, a dislocated hip. What you are trying, you are doing a slow abduction, and internal rotation. What is that you are doing? You are slowly abducting the hip and internally rotating the hip. The hip will get dislocated. The hip will get reduced or relocated with a click sound. That is called ortholony. Since the head is entering the acetabulum, it's called test of entry. So you are reducing an already dislocated hip. That is called ortholony. This is possible only in the child is less than 2 months. Okay, Barlow's test is the opposite for ortholony. It is called test of exit. That is, you are receiving a newborn baby. You are suspecting DDH in the child. The child is not, at the time when it's coming to you, it's not having a dislocated hip. So you are trying to dislocate a dislocatable hip. That is called Barlow's test. And since it's a provocative test, in clinical practice we don't do. Third is called telescopic test or called piston test. See, the baby is coming to you with a dislocated hip. You are flexing the hip joint to 90 degree, flexing the knee joint to 90, pushing it down, pulling it up, like a telescope or like a piston. It comes and goes because head is out of the socket. That is called telescopic or piston test. This is positive in fracture, old non-union fracture neck of femur. This is positive in old neglected posterior dislocation of hip in an adult. So this is a non-specific test. Coming to Alice test or Galeazzi sign, make the baby lie down in a supine position, flex both the hips to 90, flex both the knee to 90. Normally, if it is a normal hip on both sides, the level of knee joint should be equal on both sides. Okay. If it is a case of DDH, on the affected side, level of the knee joint will be lower than the upper one. So this is called Alice test, other is called Galeazzi. You see, the normal hip at this level, the affected hip is slightly lower. So this is called Alice test, other is called Galeazzi sign. Okay. So, and the gait of DDH asked question, unilateral DDH gait is called Trendelenburg gait. If it is bilateral DDH, the gait is called duck waddling gait, other is called sailor's gait. Okay, sailor's gait or duck waddling gait. We will move on to the next question. Gamekeeper's thumb. I don't know, very favorite question of FMGE. This is gamekeeper's thumb. It is injury to the ulnar collateral ligament of the metacarpophalangeal joint of the thumb, injury to the radial collateral ligament of metacarpophalangeal joint of the thumb, injury to the ulnar collateral ligament of the metacarpophalangeal of index finger, injury to radial collateral ligament of metacarpophalangeal of the index finger. By this time you would have guessed, it's a straightforward theory question. Gamekeeper's thumb is nothing but injury to the ulnar collateral ligament of metacarpophalangeal joint of the thumb. This is the right answer. What is this gamekeeper's thumb? Gamekeeper's thumb is otherwise called skier's thumb. You know ski, okay, skiing, okay, in snow, hill snow, skiing. That pole is called, the stick like this they are having is called ski pole, okay. So this is due to damage of the ulnar collateral ligament of metacarpophalangeal joint due to unexpected sudden abduction of the thumb. Forced abduction of the metacarpophalangeal joint of the thumb can tear the ulnar collateral ligament. In gamekeeping, you see this image, the word is game, but it is very terrifying, man. This is common only in European countries. I don't think in our country, I have never seen. You see what happens, no, this rabbit, poor animal, rabbit. Gamekeeper used to kill a rabbit by forcing its neck into the floor and wringing, sudden pulling the rabbit so that the neck will get dislocated, rabbit will die. See, we used to kill in chicken stall, you would have seen, they will do ringing movement. This is like that, okay. So twisting movement, ringing. So ringing the neck of the rabbit, okay. Sometimes, injure the ulnar collateral ligament of the metacarpophalangeal joint. Or when they fall against, okay, with the thumb, against the ski pole, it happens. That's why it's called skier's thumb. Gamekeeper's thumb, other is called skier's thumb. Very favorite question. Incomplete ligament injury can be managed by immobilization in a thumb spica for 4 to 6 weeks. If it is a complete ligament injury with instability, surgical repair is needed. We'll move on to the next thing. All are components of Colles fracture except straightforward cake-like question. Ventral displacement, lateral displacement, lateral tilt, lateral displacement, supination. Obviously, okay, all of you would have guessed and you would have answered it correctly, except ventral displacement of the when it becomes ventral displacement, it is not called Colles, that is called Smith, reverse Colles. Okay, you see, first described in 17 by Claude Poteau. That's why this other is called Potau's fracture. It is the most common of all fractures in older people. It is not just a fracture at the lower end of the radius, but a fracture dislocation of the distal radial ulnar joint. Fracture occurs about 2.5 centimeter above the corporal extremity, radius and corticocancellous junction, purely extra-articular. See guys, please for just 10 seconds focus your attention on me. Distal radial fracture, common fractures, two. Actually, there are two fractures, common fractures. One is called Colles, another is called Barton. One is called Colles, another is called Barton. Distal radial fractures. Distal radial fracture, which is purely extra-articular, is called Colles. Distal radial fracture, which is intra-articular, is called Barton. It's called Barton. Okay. You see, that is the difference. Right. What are the 6 components of Colles fracture? Very, very important. Okay. Dorsal tilt. Dorsal displacement. Dorsal displacement. Okay. Impaction. Okay. The 4th component is lateral tilt. 5th is lateral displacement. Lateral displacement. Okay, finally it is supination. This is a golden point. You should never forget. The mnemonic which I used was D-I-L-S. DILS. DILS. That's the mnemonic which I use. In our main recording I had given DILS. Okay. It is dorsal tilt. All these are in relation to the distal fragment of the Colles fracture. Okay. So, dorsal tilt, dorsal displacement is there. This is called Colles. Instead of dorsal tilt, there is ventral tilt, ventral displacement. This is called Smith. This is called Smith. Only when you understand, you can treat the patient. Styloid process test. So, I am expecting this for past 3 years. They are not asking this question. Styloid process test. Normally, you just palpate the radial styloid and ulnar styloid. Normally, radial styloid is 2.5 centimeter distal to the ulnar styloid. When you palpate both radial styloid and ulnar styloid at the same level, that is called positive styloid process test, and the diagnosis is Colles fracture. Diagnosis is Colles fracture. The classical deformity, because of your dorsal tilt and dorsal displacement, this is called, the classical deformity is called dinner fork deformity. Okay, 1 lakh time repeated question. Dinner fork deformity. Okay, dinner fork deformity. Okay, right. And it is treated, the treatment of choice of Colles fracture is essentially conservative, POP. No need of any surgery because it is extra-articular. But the treatment of choice for Barton's fracture is surgery because it is intra-articular. Okay, so any intra-articular fracture needs surgery. Extra-articular fracture can be managed conservatively. You see, the best treatment is close to reduction, below elbow POP cast in full pronation with palmar flexion, ulnar deviation. This is called Colles cast. See, when you reduce disimpact, impaction is neutralized. When you do palmar flexion, dorsal tilt, dorsal displacement is neutralized. In full pronation, supination is neutralized. In ulnar deviation, lateral tilt, lateral displacement is neutralized. All the 6 components of Colles fracture is neutralized by this Colles cast. Okay, and patient will be immobilized like this. Okay, this is looking like this. So this position is called cotton loader's position. This question also so far unasked. Several times they are asked Colles cast, Colles cast. Colles cast immobilized in which position? If they ask, it is called cotton loader. Cotton loader is this machine. Okay, cotton loader. Okay, cotton loader's position. Right, good. And coming to complication of Colles, you should be very careful. Most common complication is stiffness of finger. Second common complication alone is malunion. So, most common complication of Colles, when they ask a question, please read all the 4 choices. If stiffness of finger is not there, then your answer is malunion. If stiffness of finger is there, that is the best answer. Okay, you should be very careful. And Colles fracture is an important cause for carpal tunnel syndrome. So, median nerve compression. So, which nerve is compressed in Colles fracture? Median nerve, because of carpal tunnel syndrome. Okay, which tendon is ruptured in Colles fracture? So far, they had not asked. Extensor pollicis is longest tendon. EPL tendon rupture is rare. Okay, yes. Coming to the next question. This is again an image-based question. Carefully look at the X-ray. A 40-year-old female presented with on and off knee pain. Waxing and waning. Not continuous. Waxing and waning. Okay. So the diagnosis is inflammatory arthritis. Continuous pain, degenerative arthritis. Dear friends, okay, you should be very careful. A female patient, continuous knee pain. Slowly worsening over years, degenerative. Pain is there for 2 months, sudden, without any explanation, pain comes down. Again, pain comes. This is called waxing and waning of symptoms. It should be inflammatory arthritis. Okay, X-ray is given below. When you see this X-ray, I am seeing joint space narrowing, but it is symmetrical. Lateral side, joint space is narrowed. Medial side is equally narrowed. So this is called symmetrical joint space narrowing. The only diagnosis in the whole world is rheumatoid arthritis. If it is osteoarthritis, it's called asymmetrical joint space narrowing. I'll show you the picture. You see here, this is a rheumatoid arthritis. I am saying, see, there is joint space narrowing, which is very symmetrical. You see here, symmetrical joint space narrowing. When I see here, medial side there is narrowing, lateral side there is no narrowing, widening. So this is called asymmetrical joint space narrowing. This is called asymmetrical. So in an X-ray, you are seeing a symmetrical joint space narrowing, mild form of osteoporosis. The diagnosis is rheumatoid arthritis. In the X-ray, you are seeing asymmetrical joint space narrowing. Corners, you are seeing some osteophytes. See, hook-like things. Okay, I'll erase, you just see. They are called osteophytes. Diagnosis is osteoarthritis. Very simple. Okay, we will move on to the next question. You see, most common muscle involved in myositis ossificans. Triceps, biceps, brachialis, brachioradialis. Straightforward question. And this is a very favorite area of FMGE, myositis ossificans. Yeah, by this time you would have guessed the answer. Right answer is brachialis. Because the most common area that is affected is elbow joint, and the most common muscle that is involved is lower end of brachialis. You see, this is ossification happening in inflammatory muscle around the joint. The 4 structures, myositis ossificans is ossification happening in unwanted sites. Normally, ossification should happen either only in enchondrally or it has to be membranously. When ossification happens in unwanted structures like muscle, what are the 4 structures that are involved? Tendon, muscle, tendon, fascia, periosteum. Okay, so in myositis ossificans, it is happening in muscle, tendon, fascia and periosteum, unwanted site. And what is the most common cause? Ill-advised massage. That's the bookish word. Ill-advised massage. Who will do this? Quacks. Traditional bone setters will do this. And hematoma in the muscle is the underlying cause. And common site, I told you, elbow, most common site. And brachialis is the most common thing. Second site is hip. There, quadratus femoris muscle. Asked question. Ankle, it's called footballer's ankle. So far, unasked question. What is footballer's ankle? Myositis ossificans happening around the ankle joint. Footballers, repeated trauma by kicking the ball, medial aspect, no? So it's called footballer's ankle. Is footballer's ankle is myositis ossificans happening around the ankle joint. Very rarely it can happen around the knee joint, and that's called Pellegrini-Stedas disease. So far unasked in any of the Indian entrants. And myositis, when you see, you can see cotton wool-like appearance around the joint. Okay, cotton wool appearance around the joint. You see, X-ray active phase shows fluffy mass, mature phase shows trabeculated, well defined. So this is you are able to see a well defined calcified mass of the brachialis muscle. This is a mature stage. Isotope scan shows no increased uptake in myositis mass mature. Serum alkaline phosphatase is raised. Alkaline phosphatase is raised. Confirmed only by biopsy. Myositis is not that easy. You cannot differentiate myositis from osteogenic sarcoma. Either if the patient doesn't give history properly, you cannot differentiate myositis from osteogenic sarcoma by looking at the X-ray. Confirmation needs biopsy. Biopsy shows Ackermann zones phenomena. So far unasked in any of the Indian entrants. Whenever you see Ackermann zones phenomena, the only diagnosis is myositis. You see, this is a histopathology section. I will make it so simple for you. It is divided into 3 zones. This is zone number 1. This is zone number 2. This is zone number 3. So the innermost zone is a highly cellular zone. The middle zone is a zone of fibroelastic tissue. Outermost zone, the third zone, outermost zone is the mature well-oriented bone. You are taking a biopsy from the bone mass. In histopathology, it's showing 3 different zones. Innermost cellular zone, middle zone of fibroelastic tissue, outermost zone of mature well-oriented bone. It is called Ackermann zone phenomena or 3-layered phenomena. This is 100% confirmatory of myositis ossificans. Because in osteogenic sarcoma, the picture will be totally different. So the important differential diagnosis is osteogenic sarcoma. Coming to treatment of myositis, first thing is immobilize. Don't move the joint, immobilize. Give prophylactic indomethacin. This is the best drug, BD, for 3 to 4 weeks post-traumatic. India, drug of choice is indomethacin. When you read the Western book, drug of choice they are given for myositis ossificans is naproxen. In India, we are not using naproxen. So, indomethacin. Okay. Better avoid bisphosphonates. It can worsen the condition. Low dose irradiation within 72 hours. Once the mass is completely matured, 6 to 8 weeks mass is totally matured. It is not hot. It is not active. Then you can go for surgical excision of the myositis mass, which is the definitive management. Definitive treatment is surgical excision. Right, coming to the next topic, a very favorite topic in FMGE, most common site of Brodie's abscess. You know, osteomyelitis is divided into acute, subacute, chronic. Under subacute, most important is Brodie's abscess. So, Brodie's abscess is a subacute osteomyelitis. Most common site, proximal tibia, mandible, radius, ulna. By this time, you would have guessed the most common site is proximal tibia. Okay, mandible, it is adamantinoma. Okay, radius, nothing special. Ulna, salmonella osteomyelitis. Ulna, most common site is salmonella osteomyelitis is ulna. Brodie's abscess is proximal tibia. You see, it's a localized form of osteomyelitis in the medullary cavity surrounded by sclerotic wall. Okay, most common age second decade, most common organism as usual Staphylococcus aureus. The most common organism for osteomyelitis. Most common site is proximal tibia. Okay, you see the organism causing is of either low virulence or virulence is okay, but the host defense is very high. Okay, because the host resistance is very high. So when a subacute osteomyelitis is developing, if the organism virulence is low or the host virulence is high, okay, so it will become a subacute osteomyelitis. Most of the time, organism is destroyed by the host resistance. So, pus will become a sterile pus. Most of the time, when you aspirate, no, it won't show any organism. Clinically, chronic intermittent pain is the most common symptom. This can also present with night cries. Whenever you read night cries in proximal tibia and long bone, the first differential diagnosis that will come to our mind is osteoid osteoma, which is a benign bone tumor. You know the nidus which will release prostaglandins, okay, during a midnight and it causes night cries. So this also presents with night cries. One should be very careful, okay. And the site is also tibia. Closest possible DD is osteoid osteoma. This appears as a lytic lesion in medullary canal with a sclerotic rim. You see, an osteolytic lesion is, you see, this is the sclerotic rim. Okay, I will erase, you see. Okay, so this is the classical presentation. You see, osteolytic lesion is the sclerotic rim. This is the classical X-ray picture of picture of Brodie's abscess. This was the asked question. They had given in FMGE in on paper. This came. Okay, so differential diagnosis. Don't forget osteoid osteoma. Best treatment is surgery. Is the treatment of choice. Antibiotic won't help much. De-roofing and curettage is the standard procedure. Surgery is the treatment of for any subacute osteomyelitis. Your antibiotics won't help. Like chronic osteomyelitis, you have to go for curettage. De-roofing means break open the cortex. You go scoop away all the dead tissues. That's called de-roofing and curettage. Is the standard treatment of choice. Expected question. Please note this. We'll move on to the next topic. Housemaid's knee is suprapatellar bursitis, prepatellar bursitis, infrapatellar bursitis, ischial bursitis. Because housemaid's knee, several times asked question. Okay? Yes. By this time you would have guessed the answer. It is prepatellar bursitis is called housemaid's knee. Okay? Suprapatellar bursitis, no special name. Okay? Prepatellar bursitis is called housemaid's knee. Housemaid's knee. Okay? Because, housemaids, they used to kneel down like this and mop the floor. When they kneel down, directly patella is in friction with the ground. Repeated irritation of the prepatellar bursitis. Bursa, which is there present in front of the knee, patella. That's called prepatellar. So, repeatedly, because of the repeated irritation, it will go for bursitis. Called prepatellar bursitis is called housemaid's knee. Nowadays, that's not happening. Everyone is having a mop stick. Who is kneeling down and doing nowadays? Okay. So, this is of historical importance. Repeatedly, they are asking. Infrapatellar bursitis is called clergyman's knee. Clergyman's knee. Everyone knows who is a clergyman. Clergyman is a church father. Okay. Church pastor, father. It's called clergyman. So they used to kneel down with 90-degree knee flex. You know which area when they pray to Jesus, the God, right? How they are kneeling down there for 90-degree flexion. Which area is in constant friction with the ground? Infrapatellar area. So infrapatellar area is called clergyman's knee. Ischial bursitis. Okay, ischium is here in the hip. Ischial bursitis is called weaver's bottom. Weaver's bottom. Okay, because weavers, handloom weavers, they used to sit in a wooden plank for a very long time. They will weave a sari. So it's called weaver's bottom. Ischial bursitis is called a weaver's bottom. Right? Good. We'll move on to the next question. A 20-year-old male had history of trauma. 20-year-old male had history of trauma 7 years before. Had native treatment. His elbow is shown. What is the diagnosis? Is this a normal elbow? Is it cubitus varus? It is cubitus valgus or cubitus rectus. Obviously, when you see the carrying angle of the arm to carrying angle of the forearm is increased, and this is classically called cubitus valgus. Okay. See dear friends, focus your fullest attention. Whenever you extend the arm, you draw a line in the middle of the axis of the arm and middle of axis of the forearm. One angle is formed. This angle is formed. This is called carrying angle. Normal carrying angle in a male is 10 degree. Normal carrying angle is slightly more in a female because they have a gynecoid pelvis. While walking, it has to clear the pelvis. So, normal carrying angle of a female is 15 degree. Normal carrying angle, because male has a android pelvis. They walk like a soldier. Okay. Females, little, that angle is more because while walking, they have to clear the gynecoid pelvis. So, 15 degree is the carrying angle in a female, 10 degree is the carrying angle in a male. This is normal. When carrying angle is increased more than 20 degree, that's called cubitus valgus. When carrying angle is less than 10 degree, that is called cubitus varus. When carrying angle is 0, it is not increased, it is not decreased, straight, that's called cubitus rectus. You see this diagram. This is the normal carrying angle. This is normal elbow. This is straight. Okay, this is called cubitus rectus. This is cubitus rectus. Rectus means straight. That is why this muscle is called rectus abdominis. Straight. Rectus means straight. Okay, cubitus rectus. This is called cubitus. The carrying angle is decreased. This is called cubitus varus. Otherwise called gunstock deformity. Gunstock deformity. This is very excessive carrying. This is called valgus. Cubitus valgus. Okay, so the most common cause for cubitus varus or gunstock deformity is malunited supracondylar fracture. 1 lakh time repeated MCQ. Most common complication of malunited supracondylar fracture is cubitus varus, otherwise called gunstock deformity. Cubitus valgus, no lateral condyle fracture in a child. That is called Cubitus fracture, otherwise called fracture of necessity. Lateral condyle fracture in a child will go for cubitus valgus and tardy ulnar palsy. Okay, so this cubitus rectus again can happen in malunited supracondylar fracture. So this is normal, this is cubitus rectus, this is cubitus varus, that is cubitus valgus. Okay, we'll move on to the next question. Identify the splint. Look at the image. Asked question. Very favorite area of FMGE. This is called, I will give you the answer. This is called BB splint. BB splint stands for Bowler Braun. B-O-H-L-E-R. Bowler Braun. B-R-A-U-N. Bowler Braun splint. Bowler Braun splint. BB splint. This is used for fracture shaft of femur in an adult. Mostly this is used, okay, to stabilize fracture shaft of femur, to immobilize fracture shaft of femur in an adult. They had done an upper tibial pin traction, skeletal traction. They had connected it to a splint. This splint is called Bowler Braun splint. Okay, so now let us see. This is called Thomas splint. This again is used to immobilize fracture shaft of femur or fracture tibia, any lower limb fracture, shaft of lower limb fracture in an adult. Thomas splint. This is called skeletal traction. Okay, skeletal again to either to stabilize a dislocate. You had reduced the hip dislocation. You want to immobilize the hip dislocation for quite some time, you can use. Otherwise, shaft of femur fractures. Skeletal traction. Skeletal traction is otherwise called Russell traction. Okay, this is otherwise called. Names are very important, dear friends. Nowadays they are asking lot of named MCQs. Skeletal traction is otherwise called Russell traction. Okay, then comes cock-up splint. Okay, this is for wrist drop and the spring is there. So this is called a dynamic cock-up splint. And this is called a gallows splint. You see, this is a Balian-Low diagram. You see, shaft of femur fracture in a child. Shaft of femur fracture in a child. Okay, the best splint is gallows splint. Here I am not introduced any pin or anything inside a bone. I am tying only the skin. So gallows splint is a type of skin traction. It's a type of skin traction. What you have seen in the previous slide, this is a skeletal traction because you are introducing a pin inside the lower end of the femur. That is not allowed in a child because it's a growing bone. Epiphysis may get damaged. So I am immobilizing the skin traction. The skin traction, this is called gallows splint. This is called gallows splint. We will move on to the last question. A 70-year-old man presented with sudden bulge in his arm as shown in the picture. No history of trauma. The age is 70. No history of trauma. And he is a chronic asthmatic. You know, for asthma, the drug we will give commonly steroids. So asthmatic on steroids. What is the probable diagnosis? Muscle hypertrophy, long head of biceps tendon rupture, triceps rupture, myositis. Obviously, by this time you would have answered, all of you would have answered. This is the right answer. Long head of biceps tendon rupture. This is called Papoi sign. Papoi sign. Okay. Papoi, Papoi the sailor. Okay, you would have seen that in cartoon, no? Papoi sign. Papoi sign happens unexpected sudden rupture without trauma, sudden rupture of the biceps tendon especially long head of biceps tendon, suddenly one side it will become very prominent. Most of the time this is degenerative, and that is triggered by long-term intake of ciprofloxacin, quinolones or steroids. Okay, happens in old age. Okay, so this is called Papai's sign, and that is sudden rupture of the long head of biceps tendon. To some extent, we have completed this session of LRR for this forthcoming FMGE exam. I strongly believe all guys and girls, you are going to rock, and definitely you will clear this time. Don't worry. Right? One more advice I want to give, dear friends. See, when you search, please note down and search that in YouTube. This is in short, past 5 years topic discussions of FMGE. See, for FMGE, one extensive session for 2 hours, 10 minutes I had done a year back. You search like this: PrepLadder's FMGE flashback ortho. It is there in open YouTube now also. It is there in open YouTube, more than 1 lakh views it is there. Okay, in open YouTube. FMGE flashback, PrepLadder's FMGE flashback ortho. My session will come. Some other important topics in detail I had discussed already. So you see that YouTube, you see this YouTube. Mostly it is more than suffice for our forthcoming FMGE exam. Okay, we will rock. Okay, I'll pray to God very sincerely. All of our guys and my girls should clear. Okay, thank you so much, dear friends.